There's something I've wanted to say for years, and I've hesitated every single time because I know how it sounds. Some of my colleagues may not love this, some patients won't want to hear it either. But after watching so many people over 60 agree to procedures because they felt like they didn't have a choice, there's one thing I need every patient and every adult child sitting next to a parent in a waiting room to understand. Being offered a procedure does not mean you need to rush into it. Not always, not automatically. And after 60, that distinction can change everything. Here's the belief almost everyone walks in with: if my doctor recommends something, doing it quickly must be the safest choice. Yes, that's what most of us have been taught. Faster treatment feels like better treatment. Waiting feels like risk. Acting feels like control. But what if, after 60, that instinct is sometimes exactly backwards? Sometimes speed is the safest choice. A heart attack, a stroke, a ruptured appendix, you don't sit and think about it, but a large number of the procedures offered to older adults aren't emergencies, they're recommendations. And a recommendation isn't an order. Sometimes the smartest question isn't how soon can we do this? It's what actually happens if I wait. I want to be clear about something before we go further. I am not telling you to refuse medical care. Many of the procedures I'm about to talk about save lives and restore quality of life every single day. What I'm telling you is not to confuse "this is recommended" with "this must happen immediately." Those are two very different sentences, and after 60, the gap between them matters more than at any other point in your life. I want to give you one concept to carry through this entire video, because once you understand it, you'll start noticing it everywhere in the healthcare system. This one has a name: the momentum effect. Imagine a 72-year-old, generally healthy, still gardening, still driving to see the grandkids on weekends. At a routine visit, a doctor mentions a procedure. "We should probably take care of this. Nothing dramatic, just a suggestion." But here's what the patient hears: "This is dangerous. I need to act now." Within days, momentum takes over. A consultation gets booked, then pre-op testing, then a surgical date, then consent forms land on the kitchen table. Family members start rearranging their schedules to help with recovery. And notice something: at no point in that chain did anyone stop and ask the two questions that actually matter. What happens if we wait? Is there a less invasive option that gets me most of the benefit with less of the risk? That's the momentum effect. Every step makes the next step feel more automatic, and by the time you're signing paperwork, stopping to reconsider feels almost rude, almost like backing out of something you already agreed to, even though nothing has actually happened to your body yet. Every procedure on this list is a chance to interrupt that momentum before it interrupts your independence. We're going in countdown order, 5 down to 1, and I promise you, number 1 is the decision I most want families to understand, because once it's made, it can be very hard to walk back. Number 5 surprises people, because it's one of the most common procedures performed on older adults in this country. And in most cases, it isn't the emergency you'd assume. I'm talking about placing a coronary stent for stable angina, chest discomfort that shows up predictably, say during a walk, and settles down with rest. Not a heart attack, not an emergency room crushing chest pain event. A stable, manageable pattern. Here's why it sounds so sensible. You've been told your arteries are narrowed. A stent physically opens the blockage. Open artery, better blood flow, obviously better outcome, right? Let's say you're 71, you've had some chest tightness climbing stairs for a few months. It's manageable, but it worries you. Your doctor finds a blockage on imaging and mentions a stent. Your first thought is, fix it now, before it gets worse. But a lot of patients never hear the rest of it. For stable, non-emergency blockages, research comparing stenting to medication and lifestyle changes alone has repeatedly found that stents don't reduce the risk of future heart attacks or death in this specific situation. Their real benefit is symptom relief, Evidence suggests that stents offer no additional survival benefit over optimal medical therapy for stable angina, with lifestyle changes and medication effectively managing symptoms for most patients without the added risks. In other words, the artery gets opened, but for stable disease, that alone doesn't necessarily add years to your life. It may relieve discomfort, which is real and matters, but it's not automatically the life-saving intervention it feels like. Let me put it in plain English. Think of the blockage like a partially clogged garden hose. A stent is like forcing that section open with a metal sleeve. Your water pressure improves, but if the rest of the hose, your overall cardiovascular health, your blood pressure, your cholesterol, is still worn out, opening one section doesn't fix the whole system. And after 60, the stent itself carries real trade-offs. The procedure requires threading a catheter through your blood vessels. It requires blood-thinning medication afterward, sometimes for a year or more, which raises bleeding risk, a bigger concern when you're also more prone to falls. Recovery from any vascular complication in your 70s isn't the same as recovery in your 40s. So weigh it honestly. Symptom relief you can also often get from medication against a procedure with real recovery and bleeding considerations. Ask this instead of when can we schedule it? Is this chest pain stable or unstable? Have we fully tried medication and lifestyle changes first? What specifically would a stent add that medication alone wouldn't? Now, the exception, if the pain is new, worsening, happening at rest, or your doctor identifies high-risk blockage patterns, that's a different conversation entirely, and speed genuinely matters. This isn't about refusing stents. It's about knowing which category your chest pain falls into before you agree to the schedule. The question isn't whether a stent can work. It's whether it's solving a problem that medication couldn't have solved just as well with less risk. Up next is a different kind of danger, not the procedure itself, but what tends to happen during recovery. And that brings me to number 4, spinal fusion surgery for ordinary chronic lower back pain, not from a fracture, not from a tumor, not from a nerve being visibly pinched, but the everyday wear and tear back pain so many of us develop after 60. I understand why this one is tempting. You've lived with pain for months, maybe years. An MRI shows some disc degeneration. Surgery promises to physically stop the painful motion between two vertebrae by fusing them together. It sounds like a mechanical fix for a mechanical problem. Picture yourself at 68. You've had a nagging lower backache for 2 years. It's not stopping you from walking the dog, but it's there every day, and it's tiring. An MRI shows degenerative disc disease, which, to be honest, most of us have some version of just from living a long life. Fusion gets floated as an option. Here's the part most patients never hear. For ordinary degenerative back pain without a clear structural cause like instability or nerve compression, multiple studies and professional reviews have found that fusion surgery often performs no better than structured physical therapy and rehabilitation while carrying meaningfully higher risk. Think of your spine like a bridge made of many small joints working together. Fusing two of them is like welding two panels of that bridge solid. It can stop pain from that one joint, but it also forces the joints above and below to absorb more stress, which is why adjacent segment problems are one of the most common long-term complications of spinal fusion. Let's escalate consequences the way it actually plays out. Minor inconvenience, a longer hospital stay than you expected. Recovery, months of restricted movement and physical therapy. Medication, pain management, sometimes including opioids, during recovery. Complication, hardware failure, infection, or a fusion that doesn't fully heal, requiring a second surgery. Reduced mobility, stiffness in the fused segment becomes permanent. Loss of independence. Some older patients who go into fusion surgery walking unassisted come out needing months of help with basic tasks, and a portion never fully regain their pre-surgery mobility. Weigh that risk against what you're actually gaining, relief from pain that for many patients with non-specific back pain responds just as well over a year or two to physical therapy, targeted exercise, and weight management without the surgical risk. So ask before you sign anything. Is there clear nerve compression or instability on my imaging, or is this general degeneration? Have I given supervised physical therapy a real sustained trial? What does the surgeon's own outcome data look like for patients with my exact diagnosis? The exception here matters a lot. If you have a herniated disc pressing on a nerve causing leg weakness, loss of bladder or bowel control, or progressive numbness, that's not a wait and see situation. That's urgent, and surgery can be genuinely life-changing in the right way. This is specifically about ordinary, non-specific chronic back pain being treated as though it has only one solution. Strip away the marketing, and the real question isn't whether fusion can relieve pain. It's whether your specific pain has a specific, fixable cause, or whether you're being offered a permanent structural change for a problem that time and movement might resolve on its own. If this is starting to change how you think about the word recommended, do me a favor and share this with someone you know who's facing a decision like this right now. A parent, a spouse, a friend. It might be the conversation starter they need before their next appointment. Number 3 is more consequential, because this isn't really about one procedure, it's about a chain reaction. I'm talking about continuing aggressive cancer screening, colonoscopies, PSA tests, and the biopsies that follow, well past the age where the evidence supports it, without factoring in your actual life expectancy and health status. The logic seems airtight at first. Screening finds cancer early. Early cancer is more treatable, therefore more screening is always better. That reasoning holds up beautifully at 50. It gets more complicated at 78. Say you're 76, healthy, active, but with a couple of chronic conditions. Your doctor's office sends the routine reminder for another colonoscopy, the same one you've gotten every few years since your 50s. You book it because that's what responsible people do. But here's what nobody explains at the front desk. For many cancer screenings, professional guidelines recommend stopping or individualizing screening once life expectancy drops below roughly 10 years because the cancers these tests catch are often slow growing, and the harm from the screening process itself and everything it can trigger starts to outweigh the benefit. This is where the momentum effect becomes almost literal. The colonoscopy finds a small polyp that leads to a biopsy. The biopsy result is ambiguous. That leads to a specialist referral. The specialist orders another procedure to get a clearer look. And now you're several appointments deep with the accumulated risk of sedation, bowel prep dehydration, or a rare but real complication like perforation, chasing a finding that statistically was more likely than not to have never caused you a symptom in your remaining lifetime. Picture it like investigating a small crack in the sidewalk outside a house you're planning to sell in 6 months. Fixing every crack might matter if you're going to live there another 30 years. It matters a lot less if the timeline doesn't call for it, and the repair work itself carries its own risk of making a mess. Escalation, step by step, minor inconvenience is the prep and the day off. Recovery is grogginess from sedation. Then a biopsy for an ambiguous finding, then a specialist visit, then possibly a more invasive follow-up procedure. And at the far end, for a small number of people, a real complication from a procedure that was chasing a finding that likely never would have caused harm. Weigh that against the actual benefit, catching a slow-growing abnormality that, given your age and health, may never have become symptomatic in your lifetime. Ask this instead of just booking the next one automatically. Given my current health and life expectancy, does the evidence still support this specific screening test at my age? What would we realistically do differently if this test comes back abnormal, and is that action still worth taking? The exception, and it's an important one, if you have symptoms, unexplained bleeding, weight loss, a family history that changes your risk category, or your doctor has a specific clinical concern, that's not routine screening anymore, that's diagnostic evaluation, and it deserves prompt attention. This is about the automatic, calendar-driven repeat screening that continues simply because it always has, not about investigating an actual concern. None of this argues against early detection. It can absolutely save lives. The real question is whether, at this point in your life, this particular test is still more likely to help you than to start a chain of procedures chasing something that was never going to hurt you. Number 2 is the one I hear about from families constantly because it's so relatable and honestly a little controversial, because joint replacement genuinely is one of the most successful surgeries in modern medicine. But that success has created a problem. It's now sometimes offered to people whose arthritis is mild enough that surgery may not be their best first move. The logic feels obvious. Your knee hurts, an X-ray shows arthritis, replacing the joint replaces the source of pain. Simple cause, simple fix, put yourself at 66. You still play golf, though your knee complains on the back 9. Stairs bother you a little more than they used to. An X-ray shows moderate arthritis, and a joint replacement gets mentioned as the solution. Here's the part that gets skipped. Joint replacement tends to work best and last longest for people with severe advanced arthritis where the cartilage is essentially gone and conservative measures have already been tried and failed. For mild to moderate arthritis, physical therapy, targeted strengthening, weight management, and in some cases injections can meaningfully reduce pain and improve function, sometimes for years, without surgery at all. There's a detail that matters specifically after 60. Replacement joints don't last forever. They typically last somewhere in the range of 15 to 25 years, depending on activity level and the specific joint. If you have a knee replaced at 62, there's a real chance you'll need a second, more complicated revision surgery in your late 70s or 80s, a much higher risk operation at a much higher risk age. Think of it like replacing the transmission in a car you might trade in for a newer model in a few years versus one you plan to drive for the rest of your life. The decision changes depending on the timeline, and with joints, we're now planning around 2 procedures, not 1. Escalation, minor inconvenience, is the weeks of walker-assisted mobility right after surgery. Recovery is months of physical therapy to regain strength and range of motion. Medication includes pain control, again sometimes involving opioids in the early recovery window. Complication risk includes infection, blood clots, and stiffness that doesn't fully resolve. Reduced mobility can happen if therapy doesn't go as planned. And loss of independence is real for the weeks immediately after surgery, when many older patients need significant help at home, which is its own major life disruption to plan for. Weigh that against the alternative. For milder arthritis, a structured few months of physical therapy and strength work costs you far less risk, and for a meaningful number of patients, closes most of the gap in pain and function that surgery would have addressed. Ask before scheduling, based on my imaging, is this mild, moderate, or severe arthritis? Have I completed a real course of physical therapy and strengthening first? If I wait 2 years, what actually changes? Does the joint get harder to fix, or does it simply stay the same? The exception: severe arthritis with bone-on-bone contact, significant deformity, or pain that stopped responding to any conservative treatment and is limiting your basic daily function. That's a very different picture, and for those patients, replacement is often exactly the right call, well worth doing without delay. Whether joint replacement works isn't really in question. It clearly does for the right candidate. What matters is whether you're that candidate yet, or whether a few months of a different approach might get you most of the benefit with none of the surgical risk. And number 1 is the procedure I most want families of older adults to sit down and really think through together, because once it happens, the consequences aren't always something you can simply undo. Number one isn't a procedure most people plan for. It's one that gets decided, often quickly, during a hospital stay, which is exactly why it deserves the most careful thought of anything on this list. I'm talking about placing a feeding tube, usually through the abdominal wall directly into the stomach, for someone with advanced dementia who has stopped eating well or is having trouble swallowing safely. Here's why families say yes so quickly. And I want to be honest, it comes from love, not from a lack of thought. Your parent isn't eating. Eating is life. A feeding tube delivers nutrition directly. It feels like the only humane choice, and refusing it can feel unbearable, like choosing to let someone starve. Imagine your 84-year-old mother in the later stages of dementia. She's stopped finishing meals and has had a few frightening episodes of coughing while drinking water. In the hospital, a feeding tube gets raised as the next step, sometimes urgently, sometimes almost as a formality, a box to check before discharge. Almost nobody explains this in that moment. In advanced dementia, difficulty eating and swallowing usually isn't a separate problem you can fix. It's typically a sign that the disease itself has progressed to its later stages. And the evidence on feeding tubes in this specific situation is unusually consistent. Multiple reviews of the research, including a major professional society position statement, have found that feeding tubes in advanced dementia show no survival advantage compared to careful hand feeding, and that strong evidence points to artificial nutrition failing to prolong life or improve quality of life in patients with advanced dementia. Some meta-analyses have gone further, finding tube feeding in this population associated with a higher risk of pneumonia and pressure sores, without any improvement in survival or nutritional status. Let me say that plainly. The tube doesn't reverse the disease. In many cases, difficulty eating is the disease reaching its later stage, not a mechanical problem the tube can solve. Think of it this way. A feeding tube can restore nutrition when the plumbing is broken but the rest of the system works, like after a stroke that temporarily affects swallowing in someone who's otherwise recovering. But in advanced dementia, it's not the plumbing that's failing. It's the whole system winding down. A feeding tube can't fix that, even though it feels like it should be able to. This escalation is hard to hear. Minor inconvenience is the tube placement procedure itself, done under sedation in a person already frail. Recovery involves site care and monitoring for infection at the insertion point. Medication sometimes includes sedatives to stop a confused patient from pulling the tube out. Complication risk includes aspiration pneumonia, which the tube does not reliably prevent, since aspiration often comes from saliva, not food. Reduced mobility often follows, since tube-fed patients are sometimes physically restrained to keep them from removing it. And loss of independence here means something specific and painful, the loss of one of the last remaining pleasures and social connections dementia hasn't already taken, the simple human act of being fed a meal by someone who loves you. Now weigh that against the alternative many families don't realize exists. Careful, patient hand feeding, sometimes called comfort feeding, where a caregiver offers small amounts of food and drink at the person's own pace, accepting some risk in exchange for comfort, taste, human connection, and dignity in the time that's left. Ask, gently, before agreeing to a tube, where are we in the progression of this disease? Is this decline in eating a symptom of advanced dementia itself? What would hand feeding with support actually look like, and what would my loved one have wanted if we could ask them directly? The exception matters here too. If the swallowing difficulty comes from something separate and potentially reversible, a stroke, a temporary illness, a medication side effect, in someone who isn't in the late stages of dementia, a feeding tube can be exactly the right bridge back to normal eating. This is specifically about advanced progressive dementia, where the underlying disease is the reason food is being refused. Loving someone enough was never really the question. The real one is whether, at this stage, a tube gives them more life, or simply changes how their final chapter is spent. Before we wrap up, Here are 5 questions I'd want any patient over 60 or any adult child sitting in that appointment to ask before signing consent for something that isn't an emergency. 1. What happens if I do nothing for now, not forever, just for a while? 2. Is there a less invasive option that gets me most of the benefit? 3. What does the recovery actually look like, day by day, for someone my age and health? 4. How does this decision affect my independence, not just my diagnosis? 5. If this were your parent, what would you genuinely recommend? That last one, in my experience, tends to get the most honest answer of all. Let's bring it all together. Who? Number 5, a heart stent for stable, non-emergency chest pain, often no better than medication for reducing future risk. Number 4, spinal fusion for ordinary chronic back pain, frequently no better than physical therapy, with real added risk. Number 3, continuing aggressive cancer screening past the point your life expectancy still supports it, where the chase can cause more harm than the finding ever would have. Number 2, joint replacement for mild to moderate arthritis, often better addressed with therapy first, especially given that replacements don't last forever. And number 1, feeding tube placement in advanced dementia, a decision that, more than any other on this list, deserves to be made slowly, with full information, not in the middle of a hospital hallway. Every single one of these comes back to the same idea, the momentum effect. Once the appointment is booked, the testing is scheduled, and the consent form is on the table, stopping to ask, do I actually need this right now, starts to feel harder than just going along with it. Interrupting that momentum, even for one honest conversation, is not being difficult. It's being careful with something that matters more than almost anything else. Here's what I want you to take from all of this, not a list of procedures to avoid, but a way of thinking. Medicine after 60 isn't about doing everything that technically can be done. It's about protecting what actually matters to you, walking the dog, making it to a grandchild's graduation, cooking dinner in your own kitchen, staying in the home you love. Every one of the decisions we talked about today isn't really a medical decision in isolation. It's a decision about how you want to spend the years you have left and who you want to be while you're spending them. Before you say yes to the next procedure, slow down enough to ask whether it protects that life or quietly costs you a piece of it. If someone in your life is facing one of these decisions right now, send them this video. It might be exactly the conversation they need to have before their next appointment.